Good morning, everyone. I'd like to thank the Philippine Spine Society for inviting me and congratulate them and the officers and organizers for a very successful program. It's truly an honor to be here to give this lecture alongside my esteemed colleagues and mentors who are practically legends in our field. So, for today, I'm here to talk about adult scoliosis, its prevalence, and outcomes. I have no disclosures. So, just an outline of what I'll be talking about today. I'll briefly discuss the definition and the types of adult scoliosis, and then I'll focus on adult degenerative scoliosis and talk about the etiology and natural history. And then we'll talk about risk factors of progression, clinical and radiographic evaluation, and then we'll look at outcomes of non-operative versus operative treatment. So typically, adult scoliosis pertains to a spinal deformity in a skeletally mature patient with a Cobb angle of more than 10 degrees in the coronal plane. There are essentially two main types. The first one is the primary degenerative type, or the de novo scoliosis, which develops after skeletal maturity and is characterized by advanced degenerative changes, usually more predominant in the lumbar region. The second type is the adult idiopathic scoliosis type, which is essentially those adolescent idiopathic cases that have grown into adulthood. They develop before skeletal maturity and may or may not be symptomatic in adult life. Now, there's a third type known as the secondary degenerative scoliosis, which means it occurs in the context of another pathology, such as a pelvic obliquity from a limb length discrepancy, a hip pathology, or a transitional anomaly, or even secondary to a metabolic disease or an iatrogenic cause. It's important to remember that these types may all present with back pain, stenosis, and leg pain, and some may even have cosmetic concerns, but these are more common with the adult idiopathic curves. I won't be discussing in detail the SRS Schwab classification, which was already discussed by a previous speaker. I'd just like to point out in the study that most of the curves that they encountered were found in the thoracolumbar lumbar region, or were of the double curve type. A third of these patients don't even have any coronal deformity at all. So most of the patients that we will encounter with adult degenerative scoliosis will usually have their curves predominantly in the lumbar and thoracolumbar regions. So adult degenerative scoliosis, it develops in adulthood, can be as early as 40 years of age, but typically the patients we see are 50, 60, or 70 years old. And if you look at the epidemiology, most of the studies point to an asymmetric disc degeneration as the starting point. Again, it involves predominantly the lumbar spine. And the thing to remember about this is that the reasons, or one of the main reasons why these patients present to us, is because they have these degenerative changes within the deformity. They may already have some form of stenosis, spondylolisthesis, loss of lumbar lordosis, or even osteoporosis. So when we look at the etiology, and in most studies, asymmetric disc degeneration is usually the starting point, which eventually leads to asymmetric loading of the spinal segment. Asymmetric loading, coupled with degeneration of the other adjacent segments, triggers a vicious cycle enhancing curve progression. Degeneration of the facet joints and joint capsule laxity, vertebral body wedging, all of this leads to a multisegmental, multidirectional instability. It usually manifests as instability in the sagittal plane as spondylolisthesis, and also in the coronal plane as a translational or rotary listhesis. In addition, as this progresses, you get more kyphosis with aging. As you get more disc degeneration, you get more disc collapse, and you also get loss of lordosis. And eventually, this can end up with coronal and sagittal imbalance. Most of the studies have shown that coronal and sagittal imbalance has a strong correlation with poorer outcomes and low quality of life scores. So when we talk about prevalence of degenerative scoliosis, a recent study reports a prevalence of 13 to 68%. It is also more common in females than in males, and that the prevalence estimates were substantially higher in patients over 60 years old. So we know that there's a wide range of prevalence, usually in the 30% range. It definitely increases with age. Again, asymmetric disc degeneration is commonly seen as a starting point. Most curves will stay less than 20 degrees, but a lot of us will also encounter curves that are greater than that. Progression is usually slow, but they still progress faster than the adult idiopathic scoliosis types. When you talk about factors of progression, they're usually related to the size of the curve, usually above 30 degrees. Also, when you have more than 30% vertebral rotation at the apex, a lateral listhesis of 6 millimeters or more, and also a degenerated disc at the L5-S1 junction. Bone density also plays a major role in the progression. Now, however, a lot of these epidemiology studies report that the incidence of back pain is no different from the control groups. In fact, a good number of these patients are not symptomatic at all. So here's a more recent study that I just want to draw attention to. And this is just a continuation of some of the other studies I cited earlier. This time with a longer follow-up of about 12 years. 144 female volunteers, 42 with pre-existing scoliosis, 102 in the non-scoliosis group. As you can see, degenerative scoliosis developed in 29.4% in the group of patients without baseline scoliosis over a 12-year follow-up. Now, they looked at the risk factors for the development of the disease. As you can see here, lateral disc wedge, which is a measure of disc asymmetry, and a lateral osteophyte difference were huge considerations as significant risk factors for progression. And as you can see what they're actually recording on the figure on the right, if you see a large osteophyte on one side and not on the other, this is a bigger risk factor for progression, as well as the wedging that you see, the differences in disc height from A to B. Both are risk factors for progression or development of degenerative scoliosis. Now, they also looked at risk factors for progression in patients with pre-existing degenerative scoliosis. And they noted that younger patients, decreased lumbar lordosis, increased scoliotic angle, and an increased L4 tilt were all significant predictors for progression. The authors explained that younger age reflects a higher level of physical activity, therefore increasing mechanical stress to the spine. A decreased lumbar lordosis, which was also associated as an increased risk of sagittal imbalance, was also reported as a risk factor. An increased scoliotic angle as well as the presence of an increased L4 tilt were among the two most significant predictors in the progression of pre-existing degenerative scoliosis. Here's another article that looked at risk factors for progression of scoliosis in patients with pre-existing spinal stenosis. The authors reported that a decreased bone mineral density or an elevated BMI, as well as an SVA greater than 4, were also significant factors in progression. So when we evaluate patients with degenerative scoliosis, it is imperative that we order full-length 36-inch films. Full-length films allow us to detect global coronal and sagittal imbalance in our patients. We are also able to differentiate the adult idiopathic type from the de novo or degenerative type of scoliosis. We should take bending films to identify compensatory curves and rigidity curves, as well as flexion extension views to assess for sagittal instability. Now, oftentimes the patient may present also with radicular pain or stenosis symptoms, and then we can also request for an MRI. However, there's some difficulty in interpreting the MRI because the images usually come out polymorphic due to the three-dimensional pathology. So how do these patients present? Most of them will present with back pain and leg pain symptoms. The back pain is mainly due to the malalignment of the column that gives rise to axial or central pain located over the convexity, or from an obvious or subtle instability of one or more of the spinal segments. Leg pain or radicular symptoms comes from nerve roots that are dynamically stretched due to traction along the convexity or compressed by foraminal narrowing in the concavity. It is important to remember to evaluate these patients as we do our degenerative patients who also happen to have scoliosis. It is very important to identify the true pain generator and not readily assume that the scoliosis is the cause of all their problems. If we look at all the studies that look at what are the patients that we should operate on, again, these are the patients with larger curves, with severe back pain and more frequent leg pain, and also those patients who do not respond well to conservative treatment. So let's look at conservative treatment. A recent systematic review says that most asymptomatic patients do not readily need to be treated, although a periodic follow-up is recommended to monitor their curve progression. Medication, physical therapy, and exercises, and other forms of conservative treatment have unproven long-term efficacy and is not supported well in literature. Literature describing the effectiveness of these treatments is scarce, so further research is still necessary. When we look at operative versus non-operative treatment, a retrospective review reports that patients who underwent surgery do much better when it comes to scores for leg pain and back pain when compared to non-operative patients that had no significant change in their condition, and this is over a 2-year follow-up. A similar study also compared operative and non-operative treatment in a larger series of patients. Pre-treatment and 2-year follow-up data were collected prospectively, which included basic radiographic parameters, complications, and different numerical health scores, back pain and leg pain scores. The authors reported that non-operative treatments did not change the back pain and leg pain scores in patients with adult lumbar scoliosis after 2-year follow-up, and operative treatment significantly improved all health-related quality of life scores for patients who underwent surgery. The conclusions of this study, however, were limited by the fact that they were only able to follow up 45% of the non-operative group. In another more recent study, surgery was superior to non-operative care in both a randomized and observational cohort at 2-year follow-up based on SRS-22 subscores and ODI outcomes. The authors, however, recommend non-operative treatment in patients who are symptomatic or who are satisfied with their current spine-related condition, and surgery for patients not satisfied with their current spine health and expect improvement after treatment. Here we have a report, this time with a mean follow-up of 10 years, a single-center observational cohort study of 88 patients, all above the age of 55, with their main curves in the lumbar region. The authors reported that there was no significant difference in ODI total scores between the patients who were treated surgically and non-operatively at final follow-up of 10 years. In the surgical group, however, 40% of them had revision surgery. So what about our older patients with degenerative scoliosis? The patients who are older than 65 years old, how do they fare after undergoing operative treatment? Here's a study that says patients over the age of 65 years treated operatively had significantly less pain, a better health-related quality of life, better self-image, mental health, and they were more satisfied with their treatment than patients treated conservatively. And here we have another study that analyzed outcomes of surgery for different age groups, again after 2-year follow-up. Elderly patients reported significantly greater improvement in their health scores and back pain scores when compared to the younger patients, despite having a higher perioperative complication rate. These data demonstrate the potential benefits of surgical treatment for adult scoliosis and suggest that the elderly, despite facing a greater risk of complications, may also stand to gain a greater improvement in disability and pain with surgery. So in summary, we're all seeing more and more of these patients because our population is aging. Remember, it's always better to get full-length films for better evaluation. Asymmetric disc degeneration is key in development. Risk factors for progression are larger curves, apical rotation, lateral listhesis, lateral disc wedging, L4 tilt. Remember to always evaluate and treat the underlying pathology. Asymptomatic patients do not need treatment, just periodic monitoring for curve progression and development of symptoms. Operative treatment leads to better clinical outcomes within a 2-year follow-up, and older patients have higher risk of surgical complications but do better with surgery when compared to younger patients with degenerative lumbar scoliosis. That is my last slide. Thank you very much for your attention.